the first webinar.
And did you address the three questions that attendees can see what their response is?
So unfortunately, the questions didn't quite show up on my screen the way I intended, but I do know that one of the questions was specifically, when do we advise men start screening for prostate cancer generally in Guyana? And the answer is at 45 years of age. But if you're a Guyanese man of African descent, or especially if you have a family history of prostate cancer, we want you to start screening at age 40. If you want to recap those questions, I'm happy to go through the answers.
I don't have them in front of me. They didn't quite show up on my screen either.
Yeah, I'm sure we'll have an opportunity to go back to them.
Absolutely. But Dr. Prashad, thank you very much for taking care of that. Is there anything that you thought of before today's program that you thought would be really critical for our audience to know? Any other bit of information we may not have covered that may have jumped in your thought process?
Oh, I know we've got a lot of other important things to actually go through today. So I'm sure from that we'll be able to highlight and sort of add to a lot of our take-home messages from the last webinar. So I think I'm very comfortable in having our audience caught up in understanding that prostate cancer is the #1 cancer found in men in Guyana. It can potentially kill you. And we want to start screening at age 40 for those at high risk, or age 45 for the general population. And I'm happy to have you take it from there.
All right, great. Thank you very much for bringing us up to date to a good starting point. This juncture, I'd like to introduce to Dr. Fitzroy Marcus to our audience. Dr. Marcus, can we have you on the mic? And I'm so glad that you took the time to be here with us today, and I'm sure our audience is going to benefit greatly from hearing from you and some of the information that you have to share with us during this program this evening. Welcome to our program. Thank you for being here.
Right.
Good evening, Cosdy. Good evening, everyone. It's a pleasure being here. Thanks for having me again.
Right.
And I look forward to our time together.
Well, Dr. Marcus, since you're on the hot seat, I have a series of questions I'd like to throw in your lap and see how you respond to them. And I'm sure that you're going to provide us with answers that our listeners will be able to use along the way. My first thought is, given the focus of our discussion, which is primarily on the areas of prostate cancer, men's health and prostate cancer, when a patient comes in to see you, what are some of the first historical factors that you take a look at?
Yeah, so in addition to some of the general things mentioned in the first webinar, you need to find it from them things relating to the prostate, such as blood in the urine, difficulty passing urine, things like back pain. General symptoms can also play a part, loss of weight. So those are some general things that you ask the patient, and they can lead to a clear understanding of the prostate health.
Does a family history play any role in that? Let's say if someone comes in to see you and they have prostate cancer in their background, does that play any role in your assessment?
Definitely, definitely. As Dr. Prashad just mentioned, family history is a very strong indicator for earlier management and closer surveillance and monitoring of a patient who comes into you.
Okay. Give our audience a brief idea of the kinds of examinations that you would perform when someone comes in to see you and you suspect that they may be dealing with a prostate cancer or prostate-related issues. Because a man doesn't necessarily always have prostate cancer because he has some of the symptoms you mentioned. Is that correct?
Yes, so that's true. So again, a general exam is important, assessing the general health and well-being
Maybe we
of
should
the
load it the night
patient who's in
before.
front of you. And after you do the general assessment,
That's why I
blood
said
pressure,
we
all
proceed
things.
on the day of.
So even though we focus on prostate, we still need to do that general assessment, blood pressure checks, perhaps other risk factors, chronic diseases, hypertension, diabetes, and so on. But I know our talk is primarily dealing with the prostate. So in addition to those general checks, assessing weight loss and so on, as was mentioned again earlier, the rectal exam, which is a digital rectal exam, where a doctor uses a glove finger that's lubricated to assess the prostate, is still a part of the picture in terms of assessing a patient and deciding if the prostate is in good health. It gives a good understanding of any things that might be different, whether it be lumps, whether it be consistency, size, and so on. So that is something that is still a part of the equation. But with imaging and techniques now, many times some doctors defer it. So it might be done later on, or as we heard earlier, might not be done at all. But it's also part of the examination.
Doctor, how important is a man's family? Let's say man comes in, he has a spouse or somebody else in his life, a female partner or somebody like. How important is that person in the process?
Yes, the support of that partner, spouse, is very important. It helps them to give advice, it helps them to support the man during the process of the investigation. If any things are found, they're there to support him throughout the plan, the management, and it helps the person recognize you're not alone, and that goes a long way in terms of helping them to make decisions. So it's very important to have family members on board.
So is that something you would encourage? You would encourage your male patients who are facing these crises to bring their spouses or partners along with them when they come in to see you?
Definitely, and in many cases, I found it's actually those people who bring the men in for the investigation, the checkup, and rather than the men bring them in. So it's strongly recommended. And many times we see their spouses coming in with them. They're very reluctant, as men. So the family members play a very, very important role in the prostate assessment.
Now, we previously heard from Dr. Rashad about PSA, but I'm going to ask you a couple of questions in that line as well. In the process of making a medical determination of what may be ailing this a patient who comes in to see you, I would imagine that you would order various kinds of tests, to make a proper assessment of what's going on. So tell us again, what are some of the preliminary tests that you would perform on someone coming in to see you?
Um, so again, in addition to general things like a general blood count, their complete blood count, and so on, to zero in on the prostate, as you heard, the screening test is a prostate-specific antigen, which is found in the blood. It's a simple blood test, and it helps us based on the range to know what is happening. And we normally have a range that it should be normal in. It's roughly in some places 0 to 5. If it's a little higher than that, then it's considered to be a risk factor for enlarged prostate. And if it's much higher, then we consider prostate cancer. So that's one of the key screening tools that is used. As was mentioned as well, we have non-invasive methods such as ultrasound, which uses sound waves to detect any changes in the prostate to assess whether the prostate is what we call homogeneous, it has a uniform size and shape, if it has any lumps or anything noticed on it. So that is another tool that is used. There are more sophisticated things like the CT scans, which give a lot more detail and are also used if somebody is suspected to have prostate cancer to determine if they're spread, where they're spread in terms of the prostate. And we go into the MRI, which uses a magnetic resonance imaging to give a lot more detail even than the CT scan in terms of what is happening in the prostate. So those are some of the methods used. But in almost all cancers, the definitive tool used to make a diagnosis of a cancer is what we call a biopsy. And a part of the assessment of someone who you might strongly suspect based on their history, based on the examination, based on the initial screening things like the PSA, we can only definitively determine if somebody has prostate cancer and what it is, the type it is, by doing a biopsy. And this applies not only to prostate cancer, but as I said, to almost all cancers. To make a definitive diagnosis of a cancer, a biopsy is done.
Okay. So to tell us about the process of having a biopsy done. Is it a painful procedure? Do they have to be hospitalized? Can it be done in your office? What's that? What's involved with it?
Yeah, so the biopsy, you basically are taking a needle to take a sample of the prostate tissue. That sample is then taken on a slide and then it's looked under the microscope, and that determines if there are any cancer cells. So the common way that the biopsy is done is what we call the rectal approach, transrectal approach. We are going through the rectum with some kind of imaging. In most cases, an ultrasound is used to be able to specifically locate areas in the prostate where the samples will be taken from. And we try to take samples from more than one area. So 3 or 4 samples are taken from that area, and then the test is done to assess those cells. So that's a common method. It can be done in a urologist's office, and somebody's experienced. The other one that is now being done more in North America, and I'm sure will reach here, is where they use a perineal approach. And the perineum is the area between the scrotum and your anus, and again, using that needle guided with ultrasound, samples are taken from the prostate. That method presently more is done in a hospital, a surgical setting. You need anesthesia for that approach. So with the transrectal, generally it can be done in a urologist's office, outpatient setting, whereas in the perineal at present, you need a little more support services for this to be done, and that includes a surgical setting or hospital even.
Well, you didn't answer my question about whether it's painful or not.
Well, as I mentioned, the local one is local anesthesia. So the one is done in the office, use anesthesia. So I mean, if you bore with a needle and a syringe, there will be some pain, but it's minimal, but still local anesthetic is used. And in the case of the other test, you are on the general anesthesia, so you will not feel what's happening at the time. But afterwards, support is given towards the medication and so on, pain medication. You need to cover the patient antibiotics in terms of risk of infections and so on.
See, a man like me is a baby when it comes to needles, so it scares me, and that's one of the reasons I'm asking about the pain component because I'd probably pass out, but that's okay. It's a
Yeah,
necessary
yeah,
part of getting things done, right?
that's true.
Let's explore a little bit more about talk a little bit more about the biopsy. When someone has a biopsy and 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 let's say the biopsy presents a positive test for some kind of cancer, where do we go from there? How do you move on from that point?
Yeah, so once the test is positive, they would seek to grade the cancer and it's confirmed to be cancer. With the grading, you look at what you call low grade and a higher grade. A low grade means when they look under the microscope and they look at the cells, they are closer to your normal cells in the prostate. Whereas the higher grade, when you look at the cells under the microscope, the cells can be very far from your normal cells. So you consider a higher grade. And that has implications in terms of growth of the cancer, because a lower grade tends to mean it's a slower growing cancer. A higher grade tends to be a faster growing cancer. And that also has implications in terms of treatment for the patient who undergoes that. They used to grade from 1 to 5, primarily for those cancer. Now most of it is done from 3 to 5. That's a official like range that is used. In addition, there's something called a Gleason score, where they look at the most common cell seen under the microscope and the second most common cell seen. They add the two together and you arrive at that score. And um, based on that score as well, they have a range, and it can range from, again, some figures they give 6 to 10. So you can lie somewhere along that spectrum in terms of the Gleason score. So they look at these things to determine what we call the grading of the cancer and the scoring, and then they do groupings to decide how to approach the treatment and the management based on that grading and the score that's given.
So in the grading process, that's what numbers are good or what numbers are bad.
So generally, lower numbers tend to be good. So a 3 of 4 better than a 5 in terms of the grading. In a Gleason score, a 6 is better than a 10. So lower numbers are better than higher numbers.
So we've done a test and we found that patient presents positive tests for some kind of cancer. What are the steps that is taken from there as for treatment options? Let's talk about, where do we go from here? I have cancer. Doctor, you're telling me that I have prostate cancer. Where do I go from here?
So the plan would be always to make we call it management of the patient, which is more than just giving medications and treatment, but the whole treating the patient as a whole, that's the approach, and also trying to make, excuse me, trying to make the treatment specific and individual, personalizing that treatment. So that's the goal, that's the aim. Some cases, if somebody is on an older age range, elderly, sometimes it's more active surveillance being done rather than intervention because they might not be able to withstand the treatments and so on that would be needed. So observation, proper assessment, and so on is done.
Is that what
So we
active
call it
surveillance is? What is
yes.
that what active surveillance is?
So we check screening regularly again with the PSA, repeating imaging tests, and to make a determination on the way forward. If somebody is able to undertake treatment, then there are many options available. And again, it's something that is for the individual. There are hormones available, and those hormones can range from those that block testosterone from reaching the prostate because the prostate cells are responsive and they grow faster with testosterone, which is a male hormone. So they have hormones that are given to patients to help reduce that. In terms of that's a medical treatment, we call it. Chemotherapy, which is medications given generally to attack cancer cells, but it can have effects on the body, the side effects. Then there's even current treatments available to develop, like they consider the cancer cells as a germ, and you produce cells that are called antibodies to sort of attack this germ. And there's one treatment called immunotherapy. Then there are radiation therapies available, and out of that, the two common ones is what we call brachytherapy, which is more for long-term treatment. Small, they call seeds of radiation are placed in the prostate, and during a longer period of time, they radiate the prostate cells and kill more like slow-growing cancers. Then there's external radiation, which is more targeted, can be a little more aggressive, and that is used for patients with prostate cancers as well. And then there are options in terms of surgical. You can have major open surgery, which is called laparotomy, where you do an incision just above the pubic line. You go in, take out the entire prostate. It's a radical prostatectomy, and you remove that prostate. And in doing that, you've removed hopefully cancer. And that's one option. Now with technology as well, we have what we call laparoscopic surgery, where that big incision is not made, but there are smaller incisions made, little small holes around the abdomen, and using equipment, laparoscopic equipment, that prostate can also be removed. And with time, I know there's progression to other types of surgeries. Now, robotics are playing a part as well in surgeries. So the range of treatment might be a combination of those things I mentioned as well, that's specific for a patient, whether it be hormonal, chemotherapy, immunotherapy, radiation, or surgical approach. So those are the options available.
Now, let's back up a minute. You mentioned a fancy word, testosterone. What is that?
So it is a hormone, a male hormone, and that gives a lot of the features of masculinity. And as you grow as a teenager, you transition. It gives you things like the voice, musculature, and so on. But it also is produced in all men to stimulate production of semen and the progress of moving from, sorry, produce sperm from the stage of a mature sperm. And that hormone has a role in those functions. So it is something that is also stimulates the prostate, and it can cause the prostate to change and to grow. But it stimulates cancer cells when they're in the prostate and can cause them to grow much faster. So that's why the aim of the hormonal treatment is to block that intervention.
Oh, okay, I understand. So the hormone therapy is given to curtail the growth of the testosterone and that does the testosterone feed the cancer? Is that the
Yes,
representation
yes,
here?
that's the idea. Yes, prevent the test from feeding the cancer cells.
Okay. Um, you mentioned also the whole concept of the laparoscopic surgery, and I read somewhere recently about the robotic surgery. Is that available to the average person in your environment, or is that something foreign?
Not at present. In the public system, more surgery are being done laparoscopically, but I'm not aware of robotics as yet. They recently introduced those. But I know previously most urologists would do the open techniques, open surgeries. But with time, more people are going towards laparoscopic surgery.
Okay. So let's talk a little bit, Doc, about the surgery. I decided, let's say, for instance, I decided to have, I present a positive test, and I decided to use surgery as an option to treat the disease. Tell us what's involved with the surgical protocol. You open the person up, you remove the prostate. What's the healing process like, and all of that?
So general, the principle is the open surgeries, they're greater risk of infections, blood loss, longer healing time. So those are the options. The laparoscopic surgeries, again, there's less damage, less blood loss, and a faster healing time. So the aim of most of the surgeries are to remove prostate tissue. The prostate is, as you know, the gland around the bottom of the bladder, and it surrounds the urine tube, the urethra. So some approaches actually go and take out the tissues alone and leave what we call a capsule, which is the like a layer around the prostate. Other approaches will take out everything, and like any surgery, based on the extent of that surgery, you can have side effects or you can have complications. The aim is always to reduce complications, so that's why we try to individualize it to make it personal. Because some people might have a greater risk if you try to do certain types of surgery. Someone might have underlying conditions, heart problems, they might have chronic diseases, they're unable to withstand long periods of general anesthesia and so on. So you try to target the surgeries to the patient. Healthier, less complications, and so on. You go for the little more aggressive surgery. So the aim is to target the surgery based on the health of the patient. And it's a, as I mentioned, it's a team approach where many times there are other medical person involved in that decision. So not just a surgeon, but you need an internist, you need people who help with supporting, with therapy afterwards, in addition to urologists. So it's a team approach. As we said, family members are involved because they'll need to support So in making a decision in terms of surgery, it's a team approach.
And you also mentioned something about radiation. How does that work? Is there a separate treatment protocol?
Yeah, so again, radiation is another option. And as I mentioned, it can be localized brachytherapy, radiation, where you implant those small seeds of radiation that give off smaller doses to basically destroy or burn the cancer cells. And that is for smaller, slower growing cancers. Whereas the external radiation comes from outside, and during that cycle, it can be cycles of treatment, maybe 10 sessions or 10 cycles of treatment. You try to protect the other organs around the prostate, and as much as possible to target those cancer cells from outside of the body. So generally, it's a little more aggressive and so on than the one where you insert the small seeds of radiation within the prostate.
In your professional opinion, though, which one of these protocols are better than the other, or is any better than the other? Is radiation better than surgery? Surgery better than radiation? You get the same results? What? Tell us about that.
Yeah, so I would, as I said, I wouldn't go and say one is better than the other because it's based on the patient's need, it's based on the size of the prostate, based on the staging, based on the underlying factors that the patient might have. So most of them it's a combination. You find the things that as the medical treatments tend to be as not as aggressive, so like the hormonal treatment and so on, compared to like a surgical treatment. So in terms of comparison, I would say the hormone is less invasive. There are likely to be less complications. But I'm not saying that anyone is better because a lot depends on the patient and the diagnosis made, and then the staging and the scoring and the grouping, and then the combination of things that might be needed. So a patient might need both chemotherapy and radiation, and that's a combination treatment. Or a patient might need chemo, might need hormonal, and even do some kind of surgical intervention. So again, it's a combination of things needed to deal with that specific patient.
So those are all factors that you would discuss with the patient in helping him and his family to make a educated decision as to what line of treatment you'd like to embark upon. Is that my understanding?
Yeah. Yes, you need to have a discussion with the patient and their family.
Doc, I appreciate you taking the time to visit with us today. Thank you very much for taking the time to come and see us. And this is just the start of the conversation, right? So I'm going to ask you to come back again and see us and bring some more information that I'm sure will be beneficial to our audience. Thank you very much for joining us today.
You're welcome. It's my pleasure.
Thank you very much. Ladies and gentlemen, I hope we found some information in this discussion that is helpful and will help you to make a decision in the event such a decision becomes necessary in your journey. At this juncture, I would like to take a look around and see if Mr. Johnson is with us. Mr. Johnson, is Mr. Johnson with us? Mr. Johnson, welcome to our program. Thank you for joining us today. How are you doing, sir? Is Mr. Johnson microphone on? Producers, can you help him to get his microphone going?
Hello, Bill. We can't unmute you. You would have to unmute yourself. Was I on?
You're muted.
If you
Yeah.
look in the
Now
right,
can you hear me?
No, okay, fantastic. Mr. Johnson,
Excellent.
thank you
Yes.
very much for coming to see us, sir. We appreciate you
definitely.
taking the time to visit with us today. And I'm sure our audience is going to find some of the information that you have to share to be highly beneficial. I have a couple of questions I'd like to ask you, and I'd like for you to, inject whatever information you deem necessary and probably useful to
Yes.
our listening audience today. And we really value the fact that you took the time to come and spend some time with us today. Okay, Mr. Johnson, how old a man are you? You're a young-looking man. I didn't expect to see a man as youthful as you presenting issues in the area of prostate issues.
I am a young 62.
You're 62 years old. Okay.
Yes. Uh-huh.
So tell us a little bit about your journey. How did you come to realize that you had issues in this area?
Okay, my diagnosis has been less than a year. So in about March of 2025, I got hemorrhoids, and I've never had hemorrhoids before. And I was taking the preparation H over-the-counter things, and the hemorrhoids would come and go and come and go, and it became a bother. So when I had my exam in May of 2025, I told my doctor, look at it, why am I getting these hemorrhoids? He says that they're common, people get them all the time, and people just kind of live with them. He said, but if they're really a bother, then you can have them surgically removed. And I said, yes, I want these surgically removed because I don't like any type of pain at all, doc. And so we scheduled, that exam, he did a full exam. I said, I even want you to do a digital exam of my prostate because I'd been getting my PSA taken like every 6 months when I had my physical. And the PSA was a little bit high, it was higher than normal because then it was up to like a 6. And so I said, even do a digital exam. And he did a digital exam. He says, no, your prostate feels fine. It feels, it's not enlarged in any way. It doesn't feel like, rough or unusual. It feels like a perfectly very healthy prostate. And I said, okay, so let's get this surgery to get this hemorrhoid removed. And when I went there, those doctors said, hey, while we're here, let's check your HPV levels. Because everybody's got HPV. And if you have the lower levels, they're fine. But sometimes the higher levels of HPV can lead to like an anal cancer. And I said, okay, well, since you're there, just do that. And they did that. And they said, okay, wow, your numbers are like 12 on the HPV levels. So that might mean that you have anal cancer, but your PSA levels are still really high. Let us also check you for prostate cancer. So I had all kinds of MRIs and CAT scans and all these, CT scans. And it said, okay, it looks like you definitely have anal cancer, and it looks like you definitely have prostate cancer. And it looks like they may even have spread to your lymph nodes. So we're going to send you to an infectious doctor so we can take tests from the lymph nodes. And 1 week later, exactly 7 days later, they went to look at my lymph nodes, and there was nothing there at all. And they said it was probably just because the lymph nodes were working so hard, and that's what gave you a higher level of like this glucose going to your lymph nodes. Which again, anything like that they use as an indicator of cancer. If you have a high PSA level, they say you may have cancer. If you have high HPV levels, they say you have cancer. If we do this test and the glucose goes to a certain place, they say you may have cancer there. So I had 3 cancer diagnosis within 2 weeks. And then the lymph node one was removed because nothing was there. So we followed up with the prostate. So they said, we're going to now take some samples from your prostate. And that exam that the doctor talked about, I did it in office. I went to his office and pretty much they said, you lay down on a table and your legs are in the air, like a woman about to give birth or a woman having a pap smear. So I'm there, my legs are up in the air, and they gave me the local anesthesia like he talked about it. And they just kind of rubbed that on that that area. It's area that's called the taint. And it's between like the scrotum and the butthole. So they did that, which kind of like freezes it. Kind of like when the dentist puts like the Novocaine stuff on your gums before they give you a shot. It was the same situation, but this was down in that taint area. They did that, and they took 12 samples from me. And yes, it does hurt. You feel the pressure, and it did hurt. It wasn't like slight pain at all. Even though I had anesthesia going on, it hurt. And the doctor said mine hurt because he said, Mr. Johnson, you have a very thick perineum. I said, okay, God bless me. But it did hurt. They took 12 samples, and of those 12 samples, 4 of them, they found cancer cells. So now what they have done, they found cancer cells on like my anus floor by looking at the HPV, and they found cancer cells when they pulled out the test from my prostate. That we should move forward right away with getting you into chemotherapy, radiation therapy, and hormone therapy. And like you said, the hormone therapy were shots.
Well,
You can get
before we
shots.
move on, before we
Mhm.
start talking about treatment, let's explore a little bit more about the PSA.
Yes.
Given your age, had you had prior PSA evaluations? Did you ever go
Always,
in?
always, yes. Whenever I got a physical, I would always get everything done. I told them to check for everything. Well, because again, I know that prostate cancer was something that is prominent in men and black men, and there I was, a black man over 40. So I had been having my PSA levels taken. At first, I used to do the digital, and then they said, well, we don't have to do the digital anymore. We can just do the PSA levels, and we'll use that as an indicator. But the very last time, only because I'd had the hemorrhoid issues, I told him to do a digital as well. It's probably been about 12 years since I had my last digital exam. But this time I wanted everything done because I wanted to be very clear that nothing else was going on.
So what was the time between your last PSA and the most recent one that determined you had some kind of issue going? What was the approximate?
Uh, it was probably about 6 months.
Okay,
But
6 months.
and yeah, but it had been about a year since, because I also had a colonoscopy, because I told them to do that as well. And it had probably been a year since my colonoscopy. I had a colonoscopy in 2024, and it was absolutely nothing. And I did a
Yes.
colonoscopy in May of 2025, and it was perfectly clear.
So
And nothing was nothing.
yeah. So how did they disclose that to you, and how did you take the disclosure?
Of the diagnosis of cancer,
Right.
um, for me, it was like, I know that they were doing it because they never found a mass. They just found cells. They did a blood test as well, and they found cancer cells in the blood. They found cancer cells when it did the HPV, and they found cancer cells, but only in, like 2 or 4 of the 12 samples they took from me. So it wasn't like, to me, it didn't seem like it was definite that there was some horrible cancer that I had to deal with right away. But it was something, because when you get like diagnosis of cancer, it's a horrible thing. And I've said it before, cancer is that monster that's in the closet. Cancer is that monster that's under the bed. Nobody wants to hear about cancer. Anytime someone wants to frighten you or scare you, they talk about cancer, that this can give you cancer, that can give you cancer. They always use cancer as like the most fearful thing in the world. Back in the 80s, they did when they talked about HIV, they said it was a gay cancer. And it was not a cancer at all. But I know that they use the word cancer to always scare you. And I was not going to let that word scare me.
Okay. Now, you heard the doctor talked earlier about PSA and
Yes.
Gleason score. Did you know?
Mhm.
Do you know what those were for you?
This is my first time getting my Gleason scores taken. And they did 3 samples, and they said I had a 6, a 6, and an 8. They told me the 6 was moderate, the second 6 was moderate, but that the 8 was a high risk. And so they wanted to treat me based on the 8, because they said if we could treat the 8, that'll get rid of anything below that. And my highest was an 8, so they said, let's going to give you this treatment. And they prescribed for me 28 rounds of radiation and chemo.
Okay.
And I was supposed to go 5 days a week for 28, work days until all my treatments were done.
But you seem to have gone into treatment shortly, very short, in a very short time period
And that was
after
no,
your diagnosis.
I did not go into the treatment. That's what they wanted me to do.
Okay.
Now, and again, they confirmed it in September. So they did the test in August, and they confirmed it in September.
Mhm.
And so in October, I continued to take more like follow-up tests.
Okay.
Um, and so once they told me in September that I had cancer, I tried to wrap my head around it. And see, that September of 2025 was like the best month for me, and also the worst month. It was a worst month because I got all this cancer diagnosis things shoved on me. I'm also an actor. So also in September, Netflix called me and said that they were doing a movie with Jamie Foxx, and would I be available for the entire month of October. So I have a job where I can take family leave. So I gave that cancer note that said I had cancer to the HR department and my bosses to take the entire month of October off. They thought I was taking it off to deal with my cancer. I took it off to shoot a movie with Jamie Foxx. Like I
Well,
said,
that's an exciting proposition to take a
exactly.
time
For
off and shoot
me,
a movie.
cancer is something that I have used to like empower me. It's
Yeah.
something I'm dealing with, and I know I have it, but I'm going to use it in such a way that it does not bring me down and does not stop me from living my best life.
Appreciate that. Tell our audience how you managed to wrap your head around the whole concept of having cancer. You know, if I should be diagnosed with it, I probably would envision being
Mhm.
fearful, being frightened, being terrified, all of those things. How did you wrap your arms around that or your head around?
I refuse to let things frighten me. And also, I want to tell people that, cancer is nothing to be embarrassed about. You didn't do anything to cause this prostate cancer. If you get like lung cancer, they want to know, well, how long have you been a smoker? If you get liver cancer, well, how much did you drink? Prostate cancer, we did nothing to ruin or affect or damage our prostate. It's just something that happened. So nobody has to be afraid of it or ashamed of it. To talk about, oh, well, I've got just you. I mean, like I said, no. I'm not going to be ashamed of it. I will talk about my prostate cancer, and I've told a few people more than my family wanted me to tell that yes, I had prostate cancer, but then I also come back and let them know that I had no symptoms at all. Hemorrhoid was the only symptom I had. I say even for a man of my age, 62 years old, I sleep through the entire night, 7, 8 hours without having to get up to go to the bathroom. So my prostate is not enlarged around my bladder, causing pain and pressure on it to make me go to the bathroom. I still have a very strong urine stream. So again, it's not affecting my bladder at all. And I also tell people that I still have very strong erections and very strong ejaculations. Now, some people might find that too personal, but telling somebody you've got cancer, that you could possibly die from cancer, that is much more personal than your erections. But if you tell somebody you got cancer, they feel sorry for you. Erections, they don't know how to deal with. But I said, I've had no symptoms. I've had no problems at all. I guess you see, I am a very healthy person. And so
Okay.
I'm not going to let it bring me down because it hasn't changed my life.
So let's back up a minute and talk about did they introduce the concept of active surveillance? We heard the doctor talked about it earlier. Did they
Nope,
introduce that to
not at
you?
all. Not at all. They went straight to, we've got to treat this right away.
Okay.
And I felt that I was being rushed into treatment. And I know that hospitals and doctors, everything is for profit. So for me personally, this is just me personally, I didn't see that it was something that I had to rush right in because I told them I was going to need a second opinion. My first hospital was here in New York at NYU Lancome, which is one of the best hospitals in New York City. They have places all over. It's a teaching hospital. It's everything. Some of the best doctors come out of NYU. And they said, yes, you've got these cancers. So and they wanted me to start treatment in December of 2025. So they find it in October, November, December, they want to start treating it. They never talked about any kind of active surveillance, even though they never were able to say, oh, you've got a cancer mass is, 3 centimeters or anything like that. They never said you're stage 4 or stage 5 or stage 6. Based on cancer cells alone, they wanted to give me this drastic treatment. And when I heard all the side effects, I said, no, I'm not ready for these side effects yet. I'm going to need a second opinion. So in March of 2026, I went to Memorial Sloan Kettering Cancer Center, also here in New York, and had them do a second look. And they came up with a similar look as, NYU.
Well, what a second opinion is, you have another doctor take a look at it. Is that something you would encourage as
Yes.
well?
Oh, definitely. Please, please, before you sign up automatically for surgery and treatment, yes, get a second opinion.
And what's
And what
involved with that? You just tell your doctor you'd like to have a
that's
second opinion?
starting all over again. So it's finding another healthcare system because I wanted something outside of NYU. And since Memorial Sloan Kettering specializes in cancer, I went to them and made appointments. And they started the process all over again with more MRIs and more CAT scans and PET scans and CT scans. So I did those same tests all over again and blood tests. Now, when I went in for the exam for the anal cancer for the screening for that because they wanted to take their own biopsy. And while you were taking biopsies, which they could send them, they went in to take biopsies for the anal cancer at Memorial Sloan Kettering. And when they went in, and again, I was awake and watching it on the screen. She went in, with the light and the scope for my anus, and she didn't see anything. And she asked the assistant who was looking at NYU's results, saying, "Well, what quadrant or where did they say that his cancer was located anally?" And she told them where they said, and we looked there. She moved the camera all around, and she says, "I don't see anything. I don't see any darkness, any discoloration, any roughness." She said, "I don't even see where they removed any kind of biopsy from the first place. There was
Because you're a
absolutely
man in
nothing
good
there."
health.
But in October of 2025, NYU was sure that there was cancer. Now in March of 2026, Memorial Sloan Kettering cannot find it. So they said, we're going to do a deeper scope. That's when they did more of the MRI stuff. And they said, well, it looks like it's not like a mass is on top, but possibly like buried in the flesh. That's where the cells are. So that's why we can't just like scrape it up. So once again, I said, okay, it's there. So there's no tumor yet.
Well, it's a process. Now,
Exactly.
as you sit here today, tell us how do you feel? So you haven't been treated at this point. You've just been
Only
diagnosed and
thing,
all.
so I went to the doctors, and again, Memorial Sloan Kettering signed me up as well for chemo, radiation, and hormone therapy. Now, the hormone therapy, you can get a pill that you take daily, or you could get injections, and injections are every 3 months. So I've taken the every 3 months hormone shots because, like you said, that's the least invasive. So the very first time you go, you get a shot on each side of your stomach, and it goes right into like your abdomen muscles. So that actually hurts, and you kind of get like you can feel like a little bulge or a knot inside where the stuff is injected. And it hurts for a couple of days. You have to put ice on it because also it's going right into your abs. So anytime you like cough or sit up or move, you feel those shots. The second one, as you keep that for a month, and they said that's kind of like a preliminary thing to first inject you, because they said sometimes if they give you the first testosterone injection blocker, it actually raises the testosterone. So the second one is kind of like a preload situation. And then 1 month later, I went back for the actual 3-month testosterone injection, and that they injected into like the muscle right at the top of your hip, right like where the fatty tissue of your butt begins. That you don't feel at all. But what I do get is I get hot flashes, and there is moodiness because they tell me that with these shots will definitely what these shots give you is menopause. So you get the same symptoms that women get with menopause with these hormone shots because you're blocking your testosterone, which allows the estrogen, which we naturally have in our body, to flourish. So with that, I get hot flashes. I also get when hot flashes start, it starts up with like sweat on the forehead. Then you feel it behind your neck, and then under the arms, and then like what will be your breasts or your pecs start to get warm, and your nipples get very sensitive. And the hot flashes can last probably 5 to 7 minutes. And sometimes it's just one for the day. And sometimes you get several.
Yeah, okay. Well, you know what? I really appreciate your braveness in coming forward and sharing this detailed information with us. We're gonna have to leave it at the hot flashes today, but I would like to invite you to come back and visit with us another time. I'm sure our audience is going to have some questions about that, and depending on what happens, we might invite you to come back another time. Would you be willing to come back and explore some more with us?
Yes, and you can share my email in the chat or whatever like that if they want to contact me directly as well.
All right, man. Thank you very much for coming and spending some time with us today. We
You're
value
welcome.
that. We value
This
the
has been a very
information you
helpful.
shared
This has
with
been
us.
very helpful for me too. This is extremely helpful in talking to other people about it.
Good. Thank you very much.
But tell these guys, do not be afraid. Do not be ashamed.
Good. Thank you. Thank you, Bill. Ladies and gentlemen, we hope you found this information to be beneficial. We're going into a moment here where we'd like to have you participate by putting into the chat any questions that you may have about any of the information we shared with you today. Let's see if we have some questions that merits answers. And Dr. Prashad and Dr. Marcus, I'm going to ask you both to jump in and try and answer some of our audience's questions. So the first question we have up here is, what are some of the cancerous reasons PSA levels may be elevated? Dr. Prashad, how about if I throw that in your lap? Dr. Prashad? Dr. Marcus? Our doctor still with us?
Yes, Dr. Marcus is with us. Dr. Marcus,
Mar
you're muted.
Dr. Marcus, can you hear me?
Okay, yes. I wasn't able to
Is
unmute.
the
Sorry about
question
that.
is the question is, what are some of the non-cancerous reasons why a PSA may be elevated?
Yes, so as we mentioned earlier, things like the enlarged prostate, what we call benign prostatic enlargement or hypertrophy or hyperplasia, it can be a reason for an elevated prostate, the PSA test, sorry. Things like infections. If you have an infection, it could also cause an elevated PSA. And even that's why sometimes before you do a test as well, they advise not to have rigorous activity. So exercise, cycling, and so on, trauma sort of could cause some elevation in your PSA. So you can have sort of traumatic events, you can have infections, you can have benign conditions causing elevated PSA, and they are not cancerous. Yes. I don't know if you heard me. Causey, I think you're muted now.
Doc, I'd heard that there are other areas of the body other than the prostate that may produce PSA. Is that a true representation?
No, not as far as we read medically. That's why it calls prostate specific antigen. Only
Okay,
the prostate produces this antigen here.
all right. Now, another question is, what information can the MRI provide that the PSA cannot?
So the MRI is very helpful in terms of assessing the whole prostate. The actually, as you might know, the machine is a large tube. They pass through it, and it takes slices of your prostate, very thin microscopic slices. So it gives a lot of detail on what's happening in the prostate, and it also would help to identify if there's anything that you notice in terms of the prostate, any cells, any abnormal areas in the prostate. So it's very helpful. And even sometimes if there's a suspect of something happening, they can inject a dye into your veins to do what we call a contrast to ensure you get a clearer picture of what the normal cells look like and what abnormal cells. We call it a MRI contrast study. But generally before they do most contrast tests, they want to ensure that your kidneys is working well, because remember that dye is a foreign body, and once you inject that dye, your body needs to be able to get rid of the dye. So they normally assess your kidneys first before attempting any contrast studies, because you don't want dye staying in as a foreign body, and then there are other complications can develop. So MRI is very helpful, and it's also helpful in terms of, as we mentioned before, treatment options, planning treatment options, what will be done. So it's helpful in assessing the prostate, and it's helpful more than the PS in that sense. It's helpful in determining exactly where is having the problem. We do contrast. And then in management, it's also helpful in how should we proceed in treating you if you want to move forward. So it's a very useful tool.
And along that line, the follow-up question is, can an MRI help to reduce unnecessary biopsies? Is there any merit to that?
Um, As I said, to really make a definitive diagnosis, you do need to do a biopsy. So it can sort of give you a suspicion, but to confirm the diagnosis. So in a sense, I guess if there's no clear mass or lump or so on, you might want to defer it. But even as you heard earlier from Bill, he didn't find a lump, he didn't find a mass. The biopsy actually found the cancer tissue. So it could, in a sense, reduce that invasive process. But to be clear on any diagnosis of cancer, especially in prostate, the biopsy is sort of the confirmation test. So the MRI is good, it's not invasive, but to really make a definitive diagnosis, biopsy is the way to go.
Now, let's say, for instance, you have a Caribbean man like me who's afraid of needles and doctors and all that sort of stuff. A biopsy doesn't sound very appealing. Are there any risks to having a biopsy done?
Yes, any medical process, whether it be simple, complicated, you always have risk.
What are
So
some of the
again,
things
as
that
you
could
heard,
happen?
yeah, so as you heard, pain after the biopsy, that takes place. Sometimes pain during the biopsy, that happens. Possibility of infections because you're sort of pushing a needle into your body. External things can get in. You're moving stuff around that perineal area. You have germs, you have organisms, so infections can occur. You can have some bleeding. It depends on the nature of the biopsy as well. Some bleeding can take place. So those are the common sort of complications from a biopsy: bleeding, infections, pain. Yes, those are the common things.
So the other question is, let's say I live in Georgetown as an example. What is the ease of access to good treatment and care?
Well, in Georgetown, we have the public hospital, which is the tertiary institution in Guyana. It's a referral hospital. So you do have a lot of options available in the public hospital system, and they're free. Also, you do have more um, persons in the private practice as well. There are urologists who are also available in Georgetown. So there are options in terms of approaching those persons, and many of them have their own clinics. They have their own, even work, the private institutions, they have a setup as well. Some can do certain procedures. I guess you have to, as Bill did, investigate, ask questions, check out to know what is available at this institution compared to the other. So there are more options available in like a Georgetown setting in our context in Guyana compared to say another part of Guyana. So there are many options available, yes.
And doctor, how about waiting time? Let's say, for instance, I have a diagnosis today, or the patient has a diagnosis today. What's the approximate waiting time between, say, diagnosis and the time when he can go in and have treatment done? Not from,
Um,
I guess what the question is, not from the medical perspective, but I guess, how much time does he have to between diagnosis and and treatment? Is he going to die between the time he's diagnosed and 3 months down the road when he gets treated?
okay, so again, some shock thing for us is as in our context in Guyana, many men don't proactively do screening. So by the time a diagnosis is made, it's in what we call a late stage of the cancer. So because of the late stage of the cancer, the risk is if nothing is done urgently, they indeed could not survive. The risk of living a long life is reduced because of many times late diagnosis. Many times men wait until they have symptoms before, and as we heard, we mentioned about the family, and many times even those symptoms, a spouse or a family member has to bring them to the hospital. And then by the time that diagnosis is confirmed, it's pretty late in the whole scheme of things. I'm sorry to say many men do succumb within a short period. So in those cases, once something can be done, they tend to be aggressive in doing it. In other cases where there's screening done and early diagnosis, there is a little more opportunity to discuss options and for progressive treatment, as was shared again, where you can start with non-invasive things like the hormonal treatments, see how those work, then you can progress to other methods over a period of months to years. But yes, not every diagnosis means imminent death. But many times, because what happens in our context, when a diagnosis is made, it's pretty late in the stage of the disease, and the risk of death is even greater because of the lateness of the diagnosis, the spread basically. So the cancer spread beyond the prostate. It might have gone to the lymph nodes. It might have gone to the areas mentioned, your back. The bones are a common area where the cancer spread, especially the backbone. It can go to your lungs and it can go to the brains. So sometimes because of a late diagnosis, the doctors tend to be more aggressive to try to at least reduce and give a longer chance for survival. So you do what you call palliative treatment, supportive treatment, and that can be something that they tend to be aggressive on.
Okay. We have another question here,
Hold on a
Doc,
second.
and this question is as follows. It says, what should men avoid doing emotionally while waiting for results? I gather that what they're asking is he's been tested and, he's had some specimens given or taken, and I guess he's waiting for the results. So what should happen? What should he be doing in the meantime?
Um, I guess it's good. It's easier said than done, but it's good to prepare your mind for all the options. The test could come back negative. Test could come back positive, and tell yourself there are options available. So don't see the possibility of once a biopsy is done that is like the test has to be done and the results have to be obtained. As I said, the results could come back negative. So it's basically prepare your mind for all the options. If it's negative, I still would need to do my screening. If it's positive, what are the options available based on the staging and where it's at? And how do I deal with those options? So it's basically prepare your mind for all the outcomes and not seeing a biopsy as a death sentence, as we're hearing, as the end of the world. Now people are surviving longer once they take treatment. People live healthier lives once they recognize early. So I would say prepare your mind for all the possibility, but recognize that there are many options available, and it can lead to longer lives in terms of expectancy, reduced mortality, and so on.
Question, Doc. It says, how can family or spouses best help someone who has been diagnosed with prostate cancer?
Yeah, so the help is supportive. They need a lot of support. Not many men are like Bill, who I mean, I really appreciate his positivity, you know. So they need that support to help them through it. Because generally men don't really talk about their health, and it's just be there for them, you know. Listen to them, ask questions, um, give them a chance to express how they're feeling, and it's good to support them if they're willing to allow somebody to go with them whenever they go to the doctor visits. So you also understand what is expected, and you can follow through if there are side effects, if something is happening based on treatment, based on what's happening. You can be better informed, so get as much education as you can. If there are groups that are able to support, connect that person, or connect yourself to those groups. So basically inform yourself, support them emotionally, and I've seen a lot of women being even stronger than the men who've been diagnosed, and that has helped them through the treatment, helped them through the whole process, and their spouse have been very supportive of them. So I think family support is very important.
Okay. You mentioned the word education, and I would envision, well, I would add education to what we're trying to do here via this forum and this series of events we're putting out there. What are your thoughts about that? What are your thoughts about this particular program and similar programs for men to try and educate them and you know make them aware of their bodies and of what is available to them. What are your general thoughts?
Yes, I'm on board. That's I'm here because I really think this is a good thing that we're doing. We're giving men accurate information because in our culture there are lots of myths. We believe a whole sort of stuff that's not accurate, and what we do, whether it be on this webinar, whether by going out with men when men are gathered and educating them, I think it helps to give people accurate information and think that is what is needed. Accurate information, and I really commend this program for what we're doing, and I commend other outreaches where they give out that accurate information so more men are informed, more men are engaged, and they can make informed decisions about their health and their well-being. So I think this
Fantastic,
is a
Doc.
good thing.
Thank you. We have two more questions before we wrap up. The following question is, what is the most important message you want men to leave with tonight, and what gives you hope about prostate cancer outcomes today?
Yeah, so one message is again, we emphasize screening is important. Diagnosis can be made when you do your screening, and there are many options available for treatment. And with time, the options are becoming better and less invasive. So there is hope if you're being diagnosed with cancer.
Right. And the last one is, I think it's more of a statement than a question. It says, I want men to leave with a message of optimism. And I think the whole purpose of us being here is to sort of plant that seed of optimism out there and let men know that options are available. Taking affirmative steps to identify their health situation is prudent, and the education we're trying to provide here is similarly important. What do you have to add to that, Doc?
No, I agree. I agree with the statement that they need to live here, being optimistic, knowing that there are lots of things that can be done. You need to know your body, not just the prostate, but our general health, because you find if somebody is healthy, they are able to function better, they're able to do a lot of things in their lives. And an aspect we didn't touch on, many men struggle mentally going through things, and that optimistic approach, that positive approach is not there. So I would like men to leave knowing that there's hope and there are many options available. So make use of them.
Dr. Marcus, you've been an invaluable asset to us this evening. Thank you for contributing to this forum. Thank you very much for taking the time to be here with us. And I hope that our audience finds value in what you had to offer this evening. Thank you very, very much for being here with us today.
It was my pleasure. You're welcome.
I'm gone.
Hello, Neville? There's no sound.
Let's try it again.
Neville, I'll just close it out.
Well, let me just check again. Okay. All right, you guys go ahead, Frankie. You go ahead.
Good evening, everyone. This is Frank, the president of Broco. Just thank you so much for coming tonight and having this hour and a half with us. I would like to thank, excuse me, those of you in the audience who have put aside the time to spend this time with us and get get some information regarding prostate cancer. I'm sorry, we had just had some hiccups, so once again, I'm sorry. We're in a learning curve here. So yes, thank you to the audience who came and put aside some time with us tonight, and a great thank you to Cosley. You did a wonderful job. Dr. Prasad, excuse me, Dr. Marcus, Bill for sharing his journey with us, and the team, the Broco team behind us tonight. Thank you so much. Everything you've done so far tonight, and in the past year and a half to promote what Broco is doing is very well appreciated. And have a good night, everyone. Thank you.
Good night.
Is scheduled for September 2026. Stay tuned for Brocode would like to say a special thank you to our sponsors, Woodlands Hospital, Eureka Medical Labs, and Idea Print and Graphics. We would also like to thank the Big People Show, Capital News, Bobby Vera 104.1 FM. Thank you all for making this webinar a reality. Brocode would like to say a special